Okay. Good afternoon, everybody. Thanks for coming, and thanks for bearing with us on the food situation and on a very busy room. But mostly, just thanks for coming and your interest in today's session. My name is Gib Clark. I'm the coordinator of the Wilson Center's Global Health Initiative, and I welcome you to today's session on global health spending, generating political support for maternal health. Really looking forward to hearing from Jeremy and Ann here in a little bit. Before we start, I want to just tell you a little bit about the Wilson Center if you haven't been before. The Woodrow Wilson Center was started in 1968 by an act of Congress to serve as the nation's official memorial to Wilson, as he was our only president who had a PhD, for better or for worse. And so the idea was to, no offense to any PhDs here, was to bring together the worlds of policy and practice and ideas. The Global Health Initiative was started a couple of years ago because the center has about 20 programs here, and pretty much all of them are doing health in one way or another, but with no real health expertise or focus within the center. So we came in to be sort of an umbrella organization for all those, but we also focus on three unique areas of our own: maternal health, health financing, and health in post-conflict and post-disaster areas. So please join us for upcoming events in those three areas. As I mentioned, we're excited to have Jeremy and Ann here today. I'm going to leave out a lot of what's in their bios, but they're available out in the hall. But I will say Jeremy Shiffman is the Associate Professor of Public Administration at the Maxwell School of Citizenship and Public Affairs at Syracuse. He directs the Development and Social Transformation Forum at the Maxwell School, which promotes dialogue and scholarly inquiry concerning social change in developing countries. Previously, he was a social worker with the UN High Commission for Refugees affiliated agency, public relations executive in Asia, a teacher in China, and he has a BA from Yale, an MA from Hopkins, and a doctorate in political science from Michigan. Ann Stars is the co-founder and the president of FCI, Family Care International, which was founded in 1987. She initiated FCI's in-country programs in Eastern and Southern Africa, and she was the head of their Africa programs before serving as vice president, ultimately becoming president. She currently serves as the co-chair of the Partnership for Maternal, Newborn, and Child Health. She has an MPA in Development Economics and a certificate in Demography from the Woodrow Wilson School, which is no relation to the Woodrow Wilson Center, although we are friendly with them, at Princeton. So anyway, I'll stop there. As I said, there's a lot more available outside. One last note, though, before we begin. You'll see a camera in the back. Like we do with most of our events here at the Wilson Center, we're webcasting this event. And that basically means it's available online, live, and then within about a week or so, we will have the video along with a summary and the PowerPoints archived on our website in perpetuity. So I'll stop there and turn it over to Jeremy.
Thank you very much, Gib, and hello, everybody. Thank you very much to the Woodrow Wilson Center for this invitation to speak here. It's a real privilege to have this opportunity. What I'd like to talk to you about today is the subject of generation of political priority for global health initiatives, a research program framework, and case study of maternal mortality. And I'll speak for about 30 minutes to make sure that there's plenty of time for the other talk, of course, and for discussion and questions. This work is based on a paper that appeared in The Lancet in 2007, and I just want to acknowledge my co-author, Stephanie Smith. I would also like to acknowledge the multiple sources of funding for this work I'm doing. And I think I'd like to begin with a question for you, because it's quite relevant to what I'm talking about. If I might ask, how many of you in the audience would consider yourself to be working on the issue of maternal survival? Okay, obviously that's going to be the largest number of hands here today. What about newborn survival? Many. What about child survival? Okay. How about HIV/AIDS? And malaria? Interesting. Health system strengthening? Wow. Okay. Very interesting. I apologize if I didn't call your cause. But this is what I'm interested in. Because basically the question that drives my research and what I'm going to talk about is this question. Why is it that some global health issues attract extensive political support in the form of attention and resources, while others remain neglected? And if you think about this, HIV/AIDS in recent years has attracted a great deal of support, attention, resources. In the past, family planning did and child immunization did. Yet other high-burden conditions that have very high mortality and morbidity, such as malnutrition, pneumonia, and diarrheal diseases, attract very little political support and resources globally. So why this variance across initiatives? As I looked into this issue, I discovered a great deal of speculation about the problem, but surprisingly little research for what I think is a pretty interesting question that we ought to know more about. And this was one of the reasons that I was prompted to begin to study maternal survival and attention for other health issues. I also encountered, and I keep hearing, 6 hypotheses that I consider probably not to be wrong, but inadequate and probably simplistic, and I'd like to start off with these. That it's about particularly powerful, rich, or glamorous individuals. Well, this just begs the question, how is it these individuals come to determine their priorities? They certainly do not do so in a vacuum. That's why I find this hypothesis not wrong, but inadequate. It's about resources, especially financial. Yes, of course it is. But this still begs the question, what explains why donors and governments give financial resources to some causes and not others? It's about what rich countries fear. Well, that could explain attention to SARS and avian flu and AIDS, but it doesn't well explain attention to river blindness, polio, and guinea worm disease, which have gotten great resources globally, because these are offer little threat to rich countries. It's about advocacy. I don't think that statement helps us very much. Almost every single cause has advocates. The more interesting question are, what are the determinants of effective advocacy and what explains strong advocacy? It's about the media. The media certainly has influence, but media scholars have shown quite conclusively that the media responds as much as it leads. It's faddish and it's random.
We like that one.
Almost certainly randomness plays a role. I'm a social scientist and we know that. There's a lot of research in agenda setting in public policy, though, that shows there are systematic elements to the agenda setting process. So it's probably not solely about these. So 6 hypotheses, simplistic, not wrong, but inadequate. A second reason that I was prompted to undertake this kind of research was a previous study I did, and then there have been other studies in a similar vein. And I was looking at donor funding for 20 communicable diseases, trying to understand who was getting money and why. And I found it was not very little matched with burden. For instance, I looked at 20 diseases, and HIV/AIDS was getting half of all the funding among these diseases, despite representing only about 30% of the burden, while pneumonia and other acute respiratory infections represented nearly an equally high burden and was getting 2% of the funding. So it just raised in me a question. That's an interesting outcome, this division. What's explaining it? So this plus my curiosity prompted me to start undertaking a research agenda. Now, I want to emphasize that my dependent variable, what I'm trying to explain, is not public health impact, it's political priority. And this is how I understand priority. It's the degree to which international and national political systems are actively international organizations are actively paying attention to an issue and then providing resources commensurate with the problem's severity. It doesn't guarantee public health impact by any means, but it may facilitate impact, and that's why we should want to investigate it. So here's what I will present today. First is this research program concerning issue ascendance in global health. Second is a preliminary framework to explain this. And third are results from the first study on this subject, which is the case of maternal death in childbirth and maternal survival, and applying the framework to try to understand results with respect to political attention globally for maternal survival. This is the research program called the Global Health Advocacy and Policy Project, or GAP, and what it is that I'm trying to do is look at 12 different global health initiatives and health itself to see what explains variance in attention. At the end of the talk, I'll present a schematic of this. The unit of analysis is the Global Health Initiative, which I understand to be a collective action effort that links organizations across borders. Oh, okay. I'll try to get through it quicker then. So the core questions are, why do some health issues receive attention and others remain neglected? And how has health, as a general issue, come to gain global prominence over the past decade? So I'm aiming to build knowledge, evidence-based knowledge concerning what works in global health advocacy, and to see if it can contribute to building sustained political attention for the health of the poor in low-income settings, drawing on social science theory to inform public health policy making. So with that, let me turn to the case of maternal survival and the framework. I don't need to go over this with this audience. You know, this is one of the leading causes of death globally for adult women of reproductive age, that there's been a 2-decade-long initiative, and that most analysts think that it hasn't yet made a big difference in maternal mortality levels. I want to emphasize that the framework I'll present to you, I by no means think I've figured this out. I simply think I've hopefully posed an interesting question and offered some initial hypotheses about this. And there are many different issues that still demand attention. The weight of the factors, how they interact with each other, whether there are missed factors and so forth. I hope it'll stimulate discussion rather than a definitive framework, because I don't think it is definitive by any means. This, in a nutshell, is the framework. And what I'm going to do is go through briefly each one of these 11 factors and relate it to maternal survival and explain what I mean. But the upshot is that we argue that you can think about political attention in terms of 4 categories of factors. How strong are the actors, and how cohesive are they? What ideas do they use to publicly position the issue? What's the political context that surrounds them, and how do they work that context? And what is the characteristic of the issue itself? Because some issues are more easily promoted than others. I want to emphasize that I don't think any of these are necessary or sufficient conditions. You can see some causes like AIDS that have attracted great political support but don't do well on some of these, and some causes that do well on some of these but haven't got political support. I'd think of it more in terms of a probabilistic relationship. In general, the findings on the Safe Motherhood Initiative, disappointing levels of political support across time due to problems in each of these 4 categories, but new momentum, especially since 2007, and I think Anne's going to be touching a lot on this, that has really sparked a new wave of attention. But why examine the past, even with this new wave? Well, it does help us identify past problems so that they might be transcended. And I also have a broader agenda here, which is I hope I can help build knowledge on issue ascendance in global health. So let me turn to actor power, category 1. First factor, policy community cohesion. What is this? Well, policy communities are networks of organizations of multiple types, from NGOs to foundations to UN agencies, to academia and bilateral donors and so forth, who share a common concern with an issue. So there are members of multiple policy communities here. Some of you may be members of several policy communities. how they coalesce, how cohesive they are, matter. Because if they're cohesive, then it enhances their political authority and legitimacy. If they're fragmented and fighting, they're not going to be listened to as much. Factor 2 is leadership. A rather obvious one, but it's worth mentioning. These are individuals acknowledged as particularly strong champions for a cause. And they matter because for many reasons, among which are they help define the issue. They help inspire action, bring together policy communities. The most often mentioned name in global health, or one of the most often, is Jim Grant for child survival as an example of this kind of leadership. Guiding institutions, what do I mean by this? Coordinating mechanisms for an initiative that help bring it together. Network, it may be one organization, it may be a network of organizations, but some kind of leadership structure. They matter. They don't necessarily always matter for getting the issue up, but for sustaining the issue, sustaining attention across time, research shows that they matter a great deal. Again, Task Force for Child Survival and Development in the past was often cited as a very effective guiding institution for the cause of child survival. The fourth element of actor power here is civil society mobilization. And these are engaged social institutions that press political authorities to act. They matter because they're sources of bottom-up grassroots pressure on political leaders to press for attention. Let me just take each of these four actor power categories and speak to the findings with respect to the Safe Motherhood Initiative. The policy community cohesion has been historically problematic in the Safe Motherhood community. There were many tensions and disagreements. In recent years, however, this cohesion has grown dramatically. Leadership, there are many talented advocates and researchers in this community, Anne being one of them. However, if you talk to most of them, they'll tell you, but there hasn't been a unifying leader. That kind of person didn't emerge. Guiding institutions. Historically, there have been no strong institutions that have brought together this issue of safe motherhood, and certainly not in the UN. The UN agencies in the past were actually fighting one another on this issue. However, it could be that institutions are emerging with respect to leadership surrounding the issue. I should mention, and this is kind of a side, but some of the maternal survival folk tell me this. Some of them wonder whether initiative still exists. I'll speak to that briefly at the end, but it's an interesting comment they make. Civil society mobilization has been relatively weak for this issue, especially if you compare it to HIV/AIDS. And there are some exceptions, to be sure, in Tanzania and other nation states, but for the most part, you don't see a lot of mobilization surrounding maternal health. And perhaps one reason is that the people most affected are poor women with little education who have little political voice in the system. They don't have access to political power. To give you a sense of some of the past tensions that existed in the policy community, one of the respondents said this to me, and I'll just read it for those in the back. People became extremely defensive about their ideas. If you didn't agree with the idea, you were bad and wrong. It was kind of like President Bush. If you are against this idea, then you are a traitor. Let me turn to category 2 of ideas. Here I distinguish between the internal and external frame. What's the internal frame? The internal frame refers to a common policy community understanding of the definition of problems and solutions, how people centrally involved in the issue, understand the issue. And it matters because it avoids fractiousness among them. Can they come to evidence-based agreements about what needs to be done? If they do, it enhances their credibility. The external frame concerns how the issue is publicly positioned to external audiences, especially political leaders, how that inspires them to act. Well, this matters because you can position many different issues in different ways. I mean, think about the many ways AIDS has been positioned as a public health problem, later as a development issue, as a security issue, as a human rights issue. There are multiple frames to HIV/AIDS. Some of these resonated, some of these didn't. And different frames may resonate to different audiences. Finance ministers may be more attentive to public or cost-benefit frames, ministers of health to public health impact frames. So you got to think about the external framing. What about the Safe Motherhood Initiative? Well, at a fundamental level, this community has always been unified because they've all agreed that maternal mortality is a neglected crisis that demands redress. But in the past, they'd had difficulty finding other points of agreement, especially surrounding solutions. I think that's far less true now. External frame. This has been a struggle to find a public positioning of the issue that resonates with political leaders. This may be changing, and I noticed that at Women Deliver, which Anne was central to, there was an attempt to pursue a development frame, which is an interesting new angle. I don't know yet whether it's working, but I'd be interested to hear your comments. What about political context? This is category 3. And the idea here is that these actors pushing these ideas are working in political environments not of their own creation, context. But they must take them into account if they wish to be effective. And many factors matter here for health. Cultural context, gender inequities, weak health systems. But if you're thinking globally about global health initiatives, there are a couple that really stand out, and I want to highlight these. One are policy windows. What these are moments in time when conditions align favorably for an issue. And they often follow disasters like tsunamis, discoveries, forums, global UN conferences. And they really matter because they present windows of opportunity for issue promotion. So the MDGs can be seen as the creation of a policy window for those health causes on it. Second element of global governance structure. If you think about any sector, trade, health, environment, energy, there are a set of global institutions that are involved in its global governance. If you notice, I created a collage here, and I meant it to be messy, of all the health agencies. Because when there is a strong, cohesive global governance structure, you create a good platform for global collective action. But very few people think that the global governance structure for health now is cohesive. And this makes collective action sometimes difficult. What about safe motherhood in these contexts? Well, policy windows, some have opened, and I mean, you couldn't have a better policy window for maternal. I mean, they got their own MDG. I don't know what more you could ask for. The question is how well they've taken advantage of it. The global governance structure, it's not ideal for safe motherhood with this complex global health architecture, as well as the difficulties within UN agencies in finding leadership there. Perhaps that's getting better. I don't know the recent developments, but historically that's been difficult in finding a home or some kind of cohesive collective structure. What about issue characteristics? Well, the idea here is that some issues are easier to promote than others inherently by the very nature of the issue. So several factors here matter. Issues with clear measures that demonstrate the severity of the problem will help a great deal. Usually people think about indicators, measures as, means of marking a level, but political scientists think of them as political tools. And numbers can really alarm politicians. In the absence of credible indicators, they can deny a problem exists, even when it does. Very much related to this, severity. Other things being equal, politicians are more likely to pay attention to problems that have a large burden relative to others. Not even primarily necessarily because they want to do the right thing and from a humanitarian imperative. They want political credit. They want to gain political capital, so they want to focus on issues that will gain them political capital. Sometimes they have a humanitarian imperative too, but effective interventions. And here I'm talking, again, I'm not a medical professional, I'm a political scientist. I'm talking from a political angle. These are means of addressing the problem backed by evidence and clearly explained. And they matter because policymakers are more likely to act on issues they think they can do something about. The worst thing to do if you want attention for your issue is to go to a policymaker or a president or a politician and explain the problem. Then they ask you what he or she should do about it, and you say, well, I don't really know. Well, they'll go say, well, I'm going to go on to the next problem. So immunized children is a very clear example of an intervention that generates political support because it's clear, cost-effective, evidence-based. There's agreement surrounding it. So what about safe motherhood and issue characteristics? Well, indicators. Maternal mortality, although there's great work being done by Wendy Graham and others on finding better ways, and Cindy Stanton, who's a good friend of mine, and many others, on measuring maternal mortality and morbidity. I think that even the experts, and I'm not one of the experts on this, will tell you that it's been harder to measure than some of the other health outcomes like fertility and child mortality. I wonder if Wendy would still say that. I don't know, but in the past it has been. Severity. Well, of course 500,000 deaths is a tragedy and way too many. But politicians think comparatively, and that's not as many as AIDS. It's not as many as malaria. And so this presents a problem for political advocacy. Effective interventions. Well, the maternal health experts that I talk to, and I never rely on my own knowledge for this, I'm not medically trained, they tell me that they do exist and we can address this problem, but they all also say they're not as easy as those for other conditions like vaccine-preventable diseases. And they also acknowledge that their past disagreements have confused politicians, and they've confused the politicians about what the politicians are being asked to do. The messages now are clearer, I think, but they weren't in the past. And here's some responses that some of the policy community members said about this issue. We focus on uncertainties. That is the truth, but it will not convince the Minister of Finance. Another told me I would go with my ideas to a donor and X would go with hers, and who was to say who was correct. So this is a summary slide of, I'd say up through 2007, what the situation was for safe motherhood. And the upshot is that on these most of these 11 factors, things did not look too good for this issue globally. And presumably this may offer an explanation as to why it is this issue did not gain global political traction. But Anne is going to talk more about this, so I'll go over this very quickly. Since 2007, it seems that a lot of good things, thankfully, have been happening for the issue of maternal survival. And I'll just not go into that because I think Anne's really much more up-to-date and knowledgeable. I'll just throw in an interesting issue. So it's also a new development is it's getting linked with child and newborn. I mean, I don't need to tell people that here. And this is an interesting issue from a political scientist's perspective because do these linkages help safe motherhood or do they hurt safe motherhood? Some people in the community feel it's a good linkage. It builds a stronger alliance, coalition. Others say it diffuses the identity of the issue, and there are disagreements across these different policy communities about where care should be delivered. So I don't know the answer to that. I'm just interested in the issue emerging. Just from an analytical perspective, it seems to me that from this analysis, 4 key challenges emerge and that are being addressed for safe motherhood globally. One is to build on the growing policy community cohesion to become a more effective political force for this issue. The second is really to push this development of external public positionings of the issue, to convince political leaders that this is an issue that deserves attention. The third is to create and build these strong guiding institutions so safe motherhood does have a home. And the fourth is to really link with grassroots civil society initiatives, bottom up. So there's collaboration there. So this becomes more movement-like in nature rather than initiative-like. I think move from initiative to movement is a positive move, but I wouldn't call it a movement yet. It doesn't have that grassroots support. Let me just conclude with a few final points about developing the framework and how I move forward with this. As I've presented this framework to many people, I've got lots of great feedback, and people have said, well, you got to think about this and this and this. And let me tell you some of the things they told me I got to think about, and I think they're right. Got to think about who opposes the issue and how these policy communities, I'm talking broadly, cross-global health initiatives deal with people who fight them, who oppose their attention for their issue. This may not be so much maternal, which attracts some opposition, but think about AIDS, think about family planning, where you do get opponents. Think about the people living with the disease as the actors. So clearly people living with AIDS, HIV/AIDS, have been very powerful actors advancing this agenda. Without them, it wouldn't have gotten as far. So the diabetes people, interestingly enough, people with diabetes are looking at the AIDS people and saying we ought to replicate what they did. So if it's a chronic condition, this, and I don't mean to sound this the wrong way, but it presents advocacy opportunities because you get this constituency that is very passionate. Private sector interests, drug development have to be thought about in this context. And media, I didn't mean to dismiss it. It's a factor. I just think people ought to know that media responds as much as it leads. Christoph doesn't, he reads, he learns. He doesn't come up with this by himself. Ideas. I think there's a lot to be learned from sociology about what make effective issue frames. The sociologists, I won't go into it now, but sociologists have a lot of insight for us about why some frames resonate and others don't. Political context, other elements of the political context, the global political economy. You can't think about malnutrition and the issue of global malnutrition without thinking about the global political economy of the food industry. A second element of political context, and I'm thinking about this a lot now, is the amount of space that exists for global health. Everybody wishes that there was unlimited space and unlimited resources. That's just naive. It's not true. It never exists. There was never unlimited resources. There never has been for anything. Doesn't mean the pool can't be expanded, but it's not unlimited. So some issues occupy the space and others have little space. So what's going on in there in these dynamics across issues? Finally, issue characteristics. Some issues are inherently more contentious. Think about abortion, and as that comes into play in safe motherhood, there we do get contentiousness and opposition. The nature of the target group, it may matter who is being affected by this. That may shape the level of political support. Fear of contagion, communicable versus non-communicable diseases, and I would just issue sexiness. Some issues attract the movie stars and are attractive to support, but I don't hear lots of people going on the street to yell out to save children from diarrheal diseases. It doesn't happen. Finally, I just wrote another paper that, because I was a little unsettled by the lack of parsimony in my original framework. 11 factors doesn't make it neat. And people kept asking me, which do you think are the key factors? Which do you think are the key? And I thought about it, and I think it's number 1, 3, and 6. Policy community, guiding institutions, and external frame. But I'm not going to go into this, but I just wrote another paper. It's going to be published in the Bulletin of the World Health Organization in August that focuses on these 3 factors as the key things with respect to the emergence of issue attention, the way policy communities frame their issues and then build institutions to perpetuate those issue frames. This is a big challenge to people who think that it has a lot to do with severity or material conditions or numbers of deaths. It's a direct challenge to that. I don't argue that that doesn't matter. I'm sure it does, but that there's a very loose connection between the two, and this is always mediated by the way we socially interpret reality. I throw this framework up, though. There were many different issues represented in the audience. You might take a look and ask yourself whether you think this framework is relevant to the issue that concerns you and the status of your issue on that framework, or whether you think I've missed factors or some factors are irrelevant. And just to conclude with a couple slides on what the future research program is, I want to develop an evidence base for what works with respect to political attention. So the next task, and I've already started on several of these studies, is to use these categories and these factors and compare across 12 different global health initiatives. Why these 4 categories? I was thinking about the population of global health initiatives, and almost all, if not all, can fit into one of 4 categories. Either they target a disease like AIDS, malaria, and pneumonia, or they target a risk factor or something connected to a risk factor like tobacco use or alcohol use, malnutrition, or they target a particular group like children, adolescents, newborns, or they're systems in orientation, like the new focus on health system strengthening or the 80s, 90s health sector reform, primary health care in the 70s and 80s. So to look at each of these clusters and compare them with respect to issue ascendants with in-depth historical analyses and see if these factors are at work or if there are other factors. So to see the factors at work, to build knowledge about issue ascendants in global health. But also to build knowledge about health itself, because how did health get on the global agenda in the past 10 years? How can we keep it there? And ask another question. How do we surmount the fragmentation that emerges from disease cause-specific health advocacy? Some of this is useful energy. It generates attention for the health causes of the poor, and some of it is fighting against each other. So these are my general goals with this research program. Build a general explanation, grounded in evidence rather than speculation or expert practitioner wisdom, and provide knowledge for advocates of neglected issues in health and global health itself on how to generate political attention. So with that, I'll just say that your hypotheses on the causes of issue ascendants in global health are welcome. Thank you.
Y'all are chuckling at my title. Those of you who have been working in maternal health or safe motherhood for a long time will know that Where is the M in MCH was a seminal 1985 article that appeared in The Lancet, written by Alan Rosenfield and Deborah Main, that really helped launch the Safe Motherhood initiative that Jeremy's been talking about. And I think I would agree with Jeremy that maternal health has risen up considerably, helped a lot by the MDGs and also by a number of other factors that I'll be talking about. And I think it is much higher on the political agenda today than it was certainly even just a few years ago, and certainly more than it was 15 or 20 years ago. But I think the challenge now is to look at the other M. Where's the money in MNCH? And what do we need to do to make it happen? So what I'm going to be doing in my presentation is basically picking up where Jeremy left off and looking at where have we come since roughly 2007 in terms of those key factors that he's identified. So he made my work much easier. All I had to kind of do was go through and use his framework and think about where we stood on the various issues that he's identified. And to give you a sneak preview, I think there's a lot of room for optimism. What we need to do right now, I think the big challenge is to turn that political prioritization into financial commitments. So Jeremy presented some of the figures here, and I think most of you are familiar with them. I just wanted to put up this slide because I think it really highlights one of the key factors about maternal mortality and how we frame it, which is the inequity angle. What you see in the left-hand side of this graph is the maternal mortality ratio in blue, turquoise, depends on how colorblind you are, and that's the number of maternal deaths, and then the green represents the maternal mortality ratio. So you can see there the huge discrepancy between developed and developing countries. And what you see on the right-hand side of the slide is those figures for 3 developing country regions, for Sub-Saharan Africa, South Asia, and Latin America. So what we see is that while far too many women are dying in the developing world as a whole, that the problem is really extremely severe in Sub-Saharan Africa, with maternal mortality ratios there that are nearly 100 times higher than they are in the developed world as a whole. So we've had 2 decades of advocacy. I'm doing my own version of the multiple logos up on the slide. not quite so messy as Jeremy's, but it represents certainly a fairly messy history. I want to stop and address one issue that Jeremy brought up in his presentation, which is the question around terminology. You will probably not hear me use the word safe motherhood very much in this presentation. While my organization, Family Care International, helped launch the Safe Motherhood Initiative in 1987 and served as the secretariat for that initiative for 17 years roughly, we actually have stopped using that term, not completely, but largely, particularly in our global advocacy. In part when we organized the Women Deliver conference that Jeremy mentioned in October 2007. And our rationale for doing so was that safe motherhood was a very useful term and a useful concept that we used in the 1980s and 1990s. And it was useful because it was something that was politically very palatable. There is no head of state or even minister of finance who is going to say that he, primarily he, some she's, oppose safe motherhood, oppose the concept of ensuring that motherhood is safe for the women of the world. But what we also found was that it had two political drawbacks. One was that it didn't motivate and engage the women's community, and in particular the feminist and women's rights communities, that many women's groups felt that the term safe motherhood constrained women by defining them as important only in terms of their childbearing role. And we also found that it was seen as too almost condescending to women, that it didn't reflect enough women's ability to engage with and do something about this issue for themselves, by themselves. So that was why when we were planning an event to mark the 20th anniversary of the Safe Motherhood Initiative, we instead coined this term and used the framework of women deliver, because women deliver babies, and that's certainly a lot of what we're talking about, but women deliver in many other ways as well for their families and communities and nations. So coming back to this question of where are we, where have we come, and what do we still need to do, probably some of you are familiar with this slide as well. It shows where we stood in 1990, the year from which the MDGs are being tracked, and where we would need to be in 2015 if we were to achieve MDG 5, improve maternal health, and specifically to achieve the first target, which is a 75% reduction in maternal mortality. As you can see, there has a sharp line downwards, which is where we would need to be if we were to achieve the target, and where we are is an almost flat line that shows just about a 1% reduction in maternal mortality ratios between 1990 and 2005, the most recent estimates that we have. So where we are right now is a situation where, as the Secretary General of the UN, Ban Ki-moon, has said, we have an MDG that is the farthest off target of all the 8 MDGs. While those global figures are pretty discouraging, certainly, and there has been a lack of progress globally, particularly if you look at just the number of maternal deaths, where we're still at a figure of around 500,000 globally, I think it's important to at least acknowledge that there has been some progress in some regions of the world. What this slide shows is that maternal mortality ratios have in fact declined significantly from somewhere between 20 to 36% in different subregions of the world, in Asia and Latin America and North Africa, where what we see is that the problem is really has not budged at all, has not improved at all in sub-Saharan Africa. And I think it's important to recognize an added fact here is if you look at sub-Saharan Africa, that region accounts for about 10% of the world's population. It accounts for about 20% of births annually. It accounts for 50% of the world's maternal deaths, and it accounts for less than 3% of the world's health workers. I think that's a pretty interesting collection of numbers and tells you a big part of the problem that we're facing. Another part of the messaging framework that the maternal health community has been using and emphasizing a lot, and this is based partly on research that the Gates Foundation has done on what kinds of messages resonate with, in particular, a general public audience, is to emphasize the fact that the problem can be solved. While globally we haven't made enormous or sufficient progress. There are countries and subregions within countries where the issue of maternal mortality has been addressed and has been, I won't say solved, but has substantially improved. Sri Lanka is the case study that I think many people are familiar with, where they invested in midwives, training and deployment of midwives, in particular in rural areas. They had high coverage. Midwives were respected members of the community and seen as professionals. That they built health clinics with referral links to hospitals, and they had an extensive monitoring and evaluation systems in place so that they could track what was going on. And there are other countries that have followed this lead. Another bit of the messaging framework that, again, addresses part of what Jeremy was talking about, and this is a messaging that we first outdoored at the Women Deliver Conference in October 2007, is to really focus on the economic aspects of this. USAID has generated an estimate that we lose about $15 billion a year in lost productivity from maternal and newborn deaths. The estimates they're being revised right now, and I'll come back to that in a minute, but roughly somewhere in the range of $5 to $7 billion a year would be needed to prevent the majority of these deaths. So if you look at this from a return on investment terminology that resonates with financial types, it's a pretty good rate of return. There are other frameworks that we use and that do resonate with other audiences, looking at it more from that justice equity framework or from a human rights framework. And I think, as Jeremy pointed out, those frameworks don't need to be exclusive of each other. You just need to be aware of what audiences you're using which framework you're using with which audience. So why has maternal health not been a priority? It seems pretty obvious. It's a terrible problem. Millions of people die, billions in lost productivity. It's solvable. So why hasn't it been solved? As Jeremy highlighted, I think focusing on severity isn't enough to make things happen. There are a number of factors that need to come into play. And so what I'm going to do now is go through briefly his 11 key factors and talk about where we stand, what's been done since 2007, and what are the prospects for getting to where we need to get. So first, if we look at the policy community cohesion, we have a range of events and actors and entities that have come into the scene in the last months or years. First is the Partnership for Maternal, Newborn, and Child Health, which brings together many of those constituencies that Jeremy talked about in his slide. It combines donors, developing country governments, UN agencies, and a range of civil society organizations, healthcare professionals, NGOs, and research academic training institutions to try and really get some cohesion around the broader, this is of course not focused just on maternal health, it's the maternal, newborn, and child health continuum. There are also some activities and some entities that have come into place that do focus specifically on maternal health, maternal mortality. There's the Women Deliver Conference that Jeremy mentioned, and that is continuing as an advocacy initiative. Just recently, many of you may be aware that the Gates Foundation just gave a grant to Engender Health of $11 million to establish a maternal health task force, which is going to focus on really bringing together the maternal health more technical and programmatic community and ensuring that the evidence that is out there is processed and analyzed and used to bring consensus on what are the priority interventions, what are the effective strategies, and what are the gaps that need to be addressed. We also have the Countdown Initiative, Countdown to 2015, which is tracking progress. Again, this is more of a continuum of care initiative, which is tracking progress in maternal, newborn, and child health. But I think it's important because it really highlights the links between maternal, newborn, and child. And we can talk in the question and answer, as Jeremy challenged us to, as to whether that is helpful or has a downside in terms of those who care about the specific sub-issues. So where are we in terms of leadership? I think we do still lack a single, strong, unifying leader for the maternal health community. I think that is absolutely true. We have leaders like Ban Ki-moon, like Thoraya Obaid of UNFPA, who speak out frequently and strongly on this issue, but they aren't focused just on this issue. We have national leaders, the Prime Minister of Norway, Prime Minister of the UK, other heads of state who talk about this issue, sometimes in combination with newborn and child health, sometimes focused specifically on maternal. And we have some prominent women who have really taken up this issue. I think the two that are focused most specifically on maternal health are Sarah Brown, the wife of the Prime Minister of the UK, and Christy Turlington, who was in our office yesterday afternoon. She's doing a film on this issue, on maternal mortality in the developing world. So there are some prospects and some potential, and I think some momentum. And Sarah Brown, I think in particular, has some real potential. But we need to see if how that gets translated into the high-level attention that we really need. So in terms of the guiding institutions, I've in fact mentioned several of these before, so I'm not going to talk a whole lot more about them. But I think it is important. These various institutions that exist are crucial for bringing together, encouraging that cohesion that Jeremy identified as essential for the maternal health community from an advocacy perspective and also from a programming perspective. And I think the Women Deliver is working with the White Ribbon Alliance and a range of other partners as well to identify a core set of strategy messages. We also have the maternal mortality campaign that some of you may be aware of. There's going to be a meeting next week in London called by Sarah Brown to bring together key advocacy players around a set of consensus objectives for maternal mortality. So I think there's a lot of potential, a lot of movement in this particular area of cohesion. So where do we stand on the civil society mobilization? I think Jeremy's right that we have a challenge in that this issue is seen as a women's issue. It's not a chronic disease. The morbidity problems can be chronic, but the main approach that has been taken to maternal mortality is that women die from it. So we don't have a sort of built-in constituency group from that perspective. But I think White Ribbon Alliance has done a tremendous amount and has made enormous amount of progress in mobilizing women's groups at the community level to bring attention to this issue and to demand action from policymakers at the local and the national level. I think there's a lot more that can be done on that level. Women Deliver is targeting to strengthen and support that kind of local advocacy. And as I've mentioned, we're really focusing on coordination around those advocacy messages. So where are we on the internal frame? I think we've made enormous progress on this front. The Women Deliver Conference identified what were then, in fact, 3 strategic pillars for improving maternal and newborn health. We've added a 4th one since then in consultation primarily with the newborn health community. And we also tinkered a little bit with the language around this for political reasons. The first pillar was actually defined at the Women Deliver Conference as reproductive health services. And we modified that to call it family planning and other reproductive health services for reasons that I'm sure will not be a mystery to a Washington, D.C. based crowd. The second pillar is skilled care during pregnancy and childbirth. The third pillar is emergency care for life-threatening complications. And then the fourth pillar that, as I mentioned, we added shortly after the Women Deliver Conference is immediate postnatal care for the mother and newborn. And that was an attempt to bring together the maternal and newborn health communities, and I'll be talking a little bit more about that in a few minutes. There's still some challenges in this area in terms of issues that are still somewhat unresolved, and why I think the efforts of the Maternal Health Task Force are going to be really critical. While much of the division that used to be problematic for the maternal health community, and I think in particular the division between the skilled care and emergency obstetric care approach has faded, and there's general recognition that both are important, that they are, as Fred Tsai, one of the grandfathers of the movement, said, that they are two sides of the same coin. We still have some challenges in terms of those who argue for short-term sort of quick fix type solutions versus those who make the argument that maternal health, maternal mortality requires long-term investments in systems, in strengthening health systems. And my view is that if we look at this from basically that both are important, it's a little bit the same solution as we had when we had the skilled care versus emergency obstetric care. I don't think we should pose those as a versus dilemma. I think both are important, but they need to be linked as well. So where are we in terms of the external frame? We've developed and worked to convey messages that resonate with different audiences. I talked about the economic argument, the Invest in Women It Pays tagline that we developed for the Women Deliver Conference. And I think it is, while we certainly haven't done a systematic scientific study on this, our general sense is that that does resonate well with policymakers, that focusing on the importance of women's well-being and women's survival for the well-being of the family, community, and including children really does resonate. We know for a fact, for example, that Prime Minister Stoltenberg of Norway initially was going to focus on MDG 4, on child survival, and was convinced to broaden the agenda, the Norwegian agenda, to MDG 5, in part because of pressure that was put on by the UK, but also because Stoltenberg recognized that if you want a healthy child, an infant, to survive to childhood and to adulthood, that having a healthy mother is critical to that, and that argument really resonated with him. We also have the human rights framework, and one of the key factors I think that has been effective for example, the HIV community, is to be clear about what is the ask, what is the price tag, and what are the interventions that we're promoting. There's still some technical work that's being done on this global price tag for maternal, newborn, and child health writ large, including reproductive health, and that should be coming out in hopefully a matter of weeks, and that will provide a strong impetus and a new basis for some renewed advocacy around maternal health and MNCH as a whole. There are still challenges. There is this question of, it's a women's issue. How can we get men and male decision makers really engaged with this? There is, I don't want to call it competition, but there certainly are other health priorities, other health issues out there. There is, of course, the economic crisis. There's U.S. aid policies and a lingering, I think, concern, sensitivity about the links between maternal health and reproductive health, and in particular the issue of abortion, as Jeremy highlighted. And there is the challenge of the complexity of health system solutions, that while my view on that is we can talk about what needs to be done without ever using the word health systems. Policy windows. What are the opportunities? As Jeremy mentioned, there is we have MDG 5, so that's a huge boon, and we have key political leaders in the UN and outside of it talking about MDG 5 as a neglected issue. I think the challenge is to turn that into the money, as we'll be talking about in a few minutes. We have some opportunities with new global health architecture mechanisms being having recently been established or under establishment. There's the International Health Partnership. There's the High-Level Task Force on Innovative Financing for Health, which has identified, while it's looking at health systems, health challenges as a whole, it has identified MDGs 4 and 5 as MDGs that are off track and that require particular attention. I think another interesting development that is quite new is a real effort to link maternal, newborn, and child health with the HIV activist community. I've been party to some discussions with various members of the HIV and AIDS advocacy community just in the last few weeks and months, and there is a real opening from that community that wasn't there even a year ago, that I think presents some really interesting potential in terms of renewed advocacy and more unified advocacy around these issues. The global governance structure, as Jeremy identified this as one of the priorities, I think we still have somewhat of a challenge on this front with maternal health. Some of you may be aware that the 4 UN agencies that work on this issue, UNFPA, UNICEF, World Bank, and WHO, issued a joint statement in July of last year, and then also reissued it in September during what I call MDG Madness that took place in New York. That talked about how they are approaching the maternal and newborn health issues and specifying a sort of division of labor for the different components of maternal health, antenatal care, skilled care during childbirth, emergency obstetric care, et cetera, and which agency was going to take a lead in terms of promoting action on this at the country level. I think it's an interesting model. I know that the donors are challenging the UN agencies to figure out what this really means in terms of implementation. So we need to take a little bit of a wait-and-see attitude, but I think it is a positive development that the UN agencies are clearly recognizing the pressure, the need to work together and to articulate a coherent framework for their action together. And I hope that it really will help move this issue forward. We also have, as I mentioned, the high-level task force on innovative financing. And I think the challenge there will be for the maternal health and the maternal, newborn, and child health community altogether to keep the spotlight on MDGs 4 and 5 for that high-level task force. In terms of indicators, as Jeremy mentioned, Impact has made some progress in terms of innovative mechanisms for tracking maternal mortality. They haven't come up with a comprehensive new approach that's going to transform things, but there are some innovative, smaller scale approaches to collecting data through using community mechanisms, through, in some cultural contexts, for example, administering the sisterhood method via surveys at markets during market days. And they've tested this and found that it's actually quite an efficient way to collect pretty accurate estimates on maternal mortality. So there are some new developments in terms of some of the measurement challenges in maternal health. We also have Countdown to 2015, this initiative for tracking progress, which isn't collecting necessarily new data, some new data in terms of some of the policy and health systems indicators. But I think it's really helpful in the sense that it compiles data on maternal, newborn, and child health in an easily accessible way through country profiles. So there's a strong focus on what's happening at the country level, and it's going to be tracked every 2 years. Another key element of Countdown that is really positive is that they've been tracking donor assistance for maternal, newborn, and child health, and in the next round in 2010, we'll also be looking at what national governments are spending on maternal, newborn, and child health. So having a more accurate picture of how much money is being invested and where it's going is a huge plus for tracking and advocacy purposes. On this question of severity, as Jeremy mentioned, 500,000 deaths per year is not a monumental figure when you compare it to some other health issues. So what the maternal health community has done is to try and frame it in different ways. One important element, which in fact is not up on this slide, is to look at the morbidity challenge, that there are 10 to 20 million, some estimates are higher, women who develop serious morbidities every year as a result of the complications of pregnancy and childbirth, and that's a huge impact. Linking also maternal death to stillbirths and to newborn deaths, where the numbers are significantly higher, and we know that both stillbirths and a significant portion of newborn deaths are the result of either the mother's poor health during pregnancy or the poor care provided during delivery. So those are programmatically directly linked. We also focus on the impact of maternal mortality and morbidity on children. What happens when the mother dies, if she dies after birth, then the newborn baby she just gave birth to is very often going to die as well. And that older children, and in particular girls, suffer considerably in terms of limited education, poor nutrition, etc. And I think the other framing issue in terms of severity is to look at it not just from the numbers, but look at it from that equity perspective that I mentioned earlier, to look at the social and economic impact. And I think also one of the things that I've been talking about more is that we need to, when we're looking at what the needs are in maternal health, we need to look not just at the 500,000 women who die, but at the fact that there are 200 million pregnancies per year. And every single one of those pregnancies, every single one of those women deserves basic care during her pregnancy and during childbirth. And that's our challenge. Where are we in terms of effective interventions? I talked about the 4 pillars that are a broader framework. There are different ways to cut this issue of effective interventions. As Jeremy mentioned, we have technical solutions to the 5 major causes of maternal mortality, of hemorrhage, infection, eclampsia, obstructed labor, and unsafe abortion. And we can focus on packaging and marketing those technological approaches and interventions. I think there is still a strong inclination within the maternal health community to recognize that those interventions need to be provided in the context of a functioning health system if they're really going to have an impact. I think one thing that is sometimes gets lost in the discourse around this issue is the need to focus on the community as well. There's a little bit of a tendency to for those of you who have seen the movie Field of Dreams, if you build it, they will come. If you provide the health services, the women will show up. And I think we don't pay enough attention sometimes to the fact that you need to have a strong outreach component, that there are social, cultural, financial obstacles out there in the community, that even if the health services are there and are of good quality, women don't always come, and we need to look at how we address that. So I'm going to end with a quote from those of you who have been around. This was on the cover of the Lancet Maternal Survival Series that was issued in, I think it was October 2006. What I said in a comment for that series then was that the next 12 to 18 months will be critical for safe motherhood advocacy, offering an unprecedented chance to redress errors of the past and take advantage of new opportunities. So we're now, in fact, more than 18 months later. Where are we, and what is the remaining challenge? So I'm modifying that quote and saying that I think our challenge now is to ensure the political commitment and financial investment to execute our strategies and to put us on the road to achieving MDG 5. So thanks, and I look forward to hearing your views on this.
Okay, thanks. Those were two excellent presentations. As I mentioned earlier, there were some graphs and there was a lot of numbers up. So the PowerPoints will be up there along with the video in about a week. So please check back on our website. We're just going to jump into the Q&A. So please wait for a colleague of mine to get you a microphone and let us know who you are. And why don't we just start back here with both questions? Yeah. So we're just going to take
That's fine. No problem.
Hi, I'm Jill Gay, and I have a question for both of you, which is the intersections of maternal health in terms of advocacy around abortion, because abortion, you've mentioned it in passing, and I'd like you, now that the global gag rule has been repealed, to actually address the issue of how the fact that since abortion is part of the numbers that lead to maternal mortality, how to make that politically palatable. Because, as Ward Cates pointed out not too long ago, this is always going to be, as much as I'm pro-choice, it's always going to be a subject of disagreement and polarization. And the other issue is around HIV, in the sense of we have now 2 million women globally who are pregnant and living with HIV, and how these separate funding streams can actually be injurious to the women who need a more complex view of the services.
Yeah, go ahead.
Okay. Neil Brandis. Actually, Jeremy, I want to pose this question to you and Ann Stars. You looked previously, I believe, at some country case studies, which you've presented in other forms. I actually want to flip around your question about hypotheses and ask you a bit about, when you look at these promising movements, whatever they are, what are the factors that either derail or sustain within your framework these movements moving forward and be able to really sort of grow in an exponential way and achieve their aims, as opposed to those which stall? And I guess I'd offer two examples. When you reflect on, say, the primary care movement, which looked very promising at one point, and you compare it to the AIDS advocacy movement and how it's sustained itself over time, reflect on your 11 criteria, other criteria, and what are the most critical elements?
Sure. Since Jeremy's still writing, I'll jump in. On the abortion issue, Jill, I think it is and is going to continue to be a challenge. You know, with the change in administration here in Washington, I think that helps a little bit. But it's remarkable for me. I'll just tell a little story. The Council on Foreign Relations hosted a two-part event in the last fall, on maternal health and on political discourse around maternal health. There was one event here in Washington, and there was one event in New York. And I was moderating one of the panels at the event in New York, and I contacted the Council on Foreign Relations, and I said, how do you want me to deal with the abortion issue? Can I provoke it? If it comes up, do you want me to squash it? How do you want me to deal with it? And they said, no, it's fine if it comes up in New York. We just don't want it to come up in Washington. So my view is that we can't and shouldn't deny the fact that unsafe abortion is a significant cause of maternal mortality, and that, in fact, if we're looking at the solutions, it is in some ways the easiest to deal with from a technological and programmatic perspective, and that there are several different elements to that solution. There's family planning to prevent the unintended, unwanted pregnancies. There's post-abortion care to deal with the complications of unsafe abortion. And there is safe abortion where that is legal and feasible. And our approach within the advocacy community, at least that I've been engaged with, is simply to be upfront about that and to deal with it purely as a public health issue. These are the deaths and morbidity that it causes, and here are the proven programmatic approaches that can be used to address it. We don't necessarily push it beyond that, and I think that that would be my suggestion in terms of how to address that moving forward. I recognize that there are contexts in which you do have to be evasive about the language that you use. I presented just last week at an event up at the UN on corporate philanthropy, and there was a panel discussion, which touched in part on why has the corporate community not engaged with maternal health in particular. And, I said abortion's part of the answer to that question, and somebody from Becton Dickinson said, yes, and if you want corporates to engage with this issue, you have to leave it off the agenda. So, you're opportunistic, and you don't talk about it where it's going to cause a really negative reaction, and if it comes up, you talk about it in that framework that I've presented. Very quickly, I think you're absolutely right that the separation of the funding streams and programmatic approaches for HIV and maternity care have been seriously problematic for pregnant women who are HIV positive, and I think that I mentioned a little bit that this coming together of the HIV and the maternal health communities, and that's a little bit more from the advocacy perspective, but I think there's been a strong push that I think is gaining momentum about the importance of addressing these issues programmatically. So I think there's a lot of dialogue around this. There's seminars and articles and so forth, and we need to push it, and we need to keep moving on it. And I think some of the changes that may be happening on the funding scene may help that to happen. I have some thoughts on this question of stalling, but since this is Jeremy's strength, I'm going to let him address that one.
Okay. Well, let me add a couple of comments to what Anne said in response to Jill's questions, but just a few because I think your answers were excellent. The idea of being nuanced and context sensitive with respect to dealing with the abortion issue makes a lot of sense to me. I mean, when you raised that question, I just was thinking of research I've done in Nigeria, where this is a major cause of maternal mortality, but you simply could not go into Kano, Nigeria, and start leading with the abortion issue. If you want this on the agenda, you would be kicked out. So one must be I think the idea of getting nuance and contextual strategies rather than having a uniform global strategy just makes so much sense politically. The second question about separate funding streams, I'm no expert on how you implement stuff, so it just raised a second question for me. I do think about political allies, and globally, the HIV/AIDS folk are probably the most powerful political or global health movement, or one of them in history, and to link with them would be valuable. I'll just put it that much out there. Now, Neil's question about sustainability, what derails, and as soon as you said comparing primary health care and AIDS, that's a very interesting comparison. How did AIDS get so much traction and primary health care fall off the ground quickly? Two things immediately popped into my head, and I don't know if this is accurate. The first is that AIDS had a huge civil society grassroots mobilization constituency grounded in people living with the disease. No, there was no such thing for primary health care. There were a few grassroots activists, but they were, you didn't see a social movement. AIDS is a social movement. The other thing is, what's the ask? The AIDS people are very clear, for the most part. They may fight amongst themselves, and they do all the time, although that helps them get attention. But, there's a clear ask about ARVs, about interventions. But what's the ask for primary health care? The primary health care people will tell you they have clear asks, but then probe a bit further, and it's not clear what they were asking for. Those are the two things that popped into my mind immediately, but I don't know if that's a comprehensive explanation.
Okay, a couple more. How about these two in the front, Will?
Thanks. Jeremy, actually, just to follow that up a minute, because it is an interesting comparison, and you didn't talk a whole lot in the framework about who it is that's raising the issue and what impact that has on its visibility and its salience. And one thing that immediately occurs to me is that the HIV movement, when it started out, was an industrialized country, middle and upper middle class movement. It took a long time to get to the developing world. We weren't hearing about HIV in Africa until, 5 years ago? And the epidemic is, we were hearing about it, but not in broad public discussion. The epidemic is 25 years old, whereas primary health care was a movement focused on poor people who don't have much of a voice. It was being promoted by middle class and upper middle class people in the industrialized world, but the people who were suffering from the problem were poor and pretty much disenfranchised. And I'd be curious about what your thoughts are on how that plays into the political salience of global health issues.
Thanks. I'm Betsy McCallan with the White Ribbon Alliance. I just actually wanted to add on two things to the framework that both of you said. And in terms of this issue of whether it gets watered down or not in linking with other groups. And I think one way that we're gaining some traction is with the message of acknowledging maternal mortality as a marker of how well a health system is functioning or not. So I'd like your thoughts on that, but I think that's something that with not only those working on other health issues like HIV and malaria, but also those that have a broader frame in terms of development as a whole and who have been much better than we have at movement, building, and groups like Amnesty International and the One Campaign and Oxfam and others who have health systems within their frame, but putting that as a key indicator helps keep the focus on maternal health and also gives a face to what is such a nebulous concept in terms of the health systems element. So yeah, I think I think that's a positive way that we can help with the integration piece.
Okay, sure. The first comment is the hypothesis, and I think it's a very interesting hypothesis, that it matters who suffers. The issue attention is shaped by the group that suffers. And it's something I mentioned at the end, but it's not in the framework, and I think it ought to be. To be blunt, if rich people get it, it's an issue, and if it's only going to kill poor people, it's kind of sad, but you see it with newborns. They have no voice. They literally and figuratively, they have no voice. So it's taken a while to get that on the agenda. There are other factors, but yeah, I think you got to look at that. And Betsy's comment about health systems as a marker for maternal mortality, I think makes a lot of sense. That gives a face to the health systems issue. Then you're asking what we think about whether that's a good framing. I don't know. I'd rather rely on research.
Jeremy, you're such an academic. I love it. Just to pick up a little bit on those comments, I think this question of who suffers and the difference between a problem that is seen as only poor people or only people in poor countries suffer, I think that's true. I think that we have untapped potential with the maternal mortality, maternal health advocacy, in that I think that this issue can resonate with women in developed countries because any woman who's been pregnant and gone through childbirth knows how frightening that experience can be and how every pregnancy faces risk. That is a reality for women everywhere in the world, regardless of what their socioeconomic and geographic situation is. And I think there's a real opportunity that women who live in places where they have good access to health care and are not likely to die from the complications of pregnancy and childbirth. It's not a big imaginative leap to think, so, I've done this myself. I've had 2 kids, and I thought, damn it, with my first child, I had retained placenta. If I'd been in the bush in a rural country in Africa, I probably would have died. And a lot of women have complications, and they can make that imaginative leap. So I think there's a real potential to get the issue to resonate with that audience, at least in developed countries. I agree with Betsy. I think there is real potential for linking this issue to broader development frameworks and to the health system's strengthening framework. But my one concern about that is that I think it's an argument that has to be used, as Jeremy has said, contextually. It's not necessarily going to, if we're talking about, for example, reaching out to this mass general public of women who might be able to relate to the experience of having a complication during pregnancy and childbirth, arguing that maternal mortality is a great indicator of health systems functionality is not going to resonate with that particular audience. So I think that's a little bit more of an internal framing, to use Jeremy's language. But I think it does have great potential.
Yeah, those couple right there, Will.
Hi, my name is Jessica Telahun, and I have a question about the linking, as well as the talking about the global health sphere and how much space each issue gets. As for the linking, are we talking about partnering, or are we talking about following their example? For example, how they address the 11 factors. How did they accomplish those 11 factors to become so successful? Because I think now, for anybody who's written a grant, if you mention certain words, HIV being one of them, regardless of what your project's doing, the success rate goes up. And is that linking? Like, what is that? I mean, people call it linking. We're linking with HIV/AIDS, but we're doing blah, blah, blah. And then as far as like the global, you were talking about how there's only so much space. And so if you're linking and you combine 2, are we diminishing the impact, or are we increasing the impact because now it's a bigger space?
Kathleen Kurz, AED, Africa's Health in 2010 project. Thank you for 2 excellent presentations, really thought-provoking. Jeremy, I'm extremely pleased to see malnutrition on your list, because last time I heard you, I recommended that, and can't wait to see what you come up with for. As I said then, if maternal mortality has problems, nutrition has more, for some of the reasons you mentioned, I think, even structurally. But my question on the Safe Motherhood Women Deliver side is a question about does focusing on adolescents, the too young in the old, and postponing age of marriage or age of childbirth, if you can separate it from age of marriage, how does that fit in the interventions? Its prevention has a lot of salience, but I know that there have been some hesitation. So in some lists for reducing maternal mortality, it's on the list, and sometimes it isn't emphasized as much. And I'm as interested from the political strategy side as much of anything, and certainly how it's worked out programmatically and policy-wise from Anne as well as from Jeremy. Thank you.
Okay, since you're so nicely grouped, just pass it up to Charlie right there. Thanks.
Charlie Teller, PRB fellow. I wanted to follow up with this issue on the data from Africa. And when we are evaluating impact of programs and both the demographic and health transition, why is it that in certain intervention areas there's been rather dramatic improvement, such as in immunization, or let's say BedNet, but in let's say in maternal malnutrition or in maternal death, there's been so little. And when we look country by country, I've looked at some of them, we see that dealing with maternal death and maternal malnutrition, you're dealing with issues much broader than medical interventions. Some countries, it seems like the interventions trying to address maternal mortality have been hijacked by the medical emergency care movement. In some countries, percent being delivered by skilled birth attendants or percent accessing antenatal haven't moved between the last two DHSs. What we see in those countries is an increase in the focus on emergency care. And I'd like to see a little bit more attention placed on the connectivity between MDG 1 and 2 and MDG 5. I didn't see much in the data. I do think that to get the attention of ministers of finance, that the connections have to be made between a health outcome and poverty, hunger, and education outcome. So I wonder what in terms of looking at certain countries and the data, why haven't there been greater movement in these African countries? And what do you think about this hijacking by the treatment folks in addressing the issue?
Well, I think you've kind of presented the solution in asking the question, and I hinted at it a little bit in my presentation, saying that I think I had that slide where I said, don't forget the community. And I think that was a little bit of a code word for the importance of addressing those broader contextual issues. I think that it's important to focus on the capacity of the health system to manage those life-threatening complications, and those basic interventions of ability to do blood transfusions, C-sections, to administer certain drugs are essential, and they have to be there if a woman's life is going to be saved. I think the risk is, and I wouldn't say that it's been hijacked by that approach, but I think that needs to be balanced by an approach that gives equal focus on making sure that the women can actually get to the facilities that can provide those life-saving interventions. And I think looking at, my organization, Family Care International, has done some interesting research that has found that basically awareness, knowledge of maternal health issues, and even awareness of risk factors had no correlation with women's use of facilities-based care for delivery. The key factors were focused counseling during the prenatal period. So if during prenatal care they were counseled by a health worker on what to do at the time of delivery, and interestingly, basically male involvement, that if they had a supportive husband with whom they had discussed a birth plan, if they had set aside money, if they had identified a health facility nearby or relatively nearby where they could deliver, there was a huge, very strong correlation between those factors and delivery in a health facility. So I think we really need to focus on those contextual, social, cultural factors that are really important to making sure that women can get to the health facilities. I don't want to take too much time. Just to answer Catherine's question, or at least address it a little bit, I think the issue of adolescent pregnancy is a neglected one. WHO is making pregnancy safer, as well as the Child and Adolescent Health Program at WHO. Both have, unfortunately at this point, I think somewhat disconnected, but hopefully they'll be coming together efforts to look at this issue of adolescent pregnancy. And I think that it is a relatively neglected issue. If we look back at the Safe Motherhood 10th anniversary conference that happened in 1997 in Sri Lanka, one of the 10 action messages that was articulated at that time was delay marriage and first birth. And I think that's been somewhat neglected. And I think we do need to refocus on that issue. I think it's partly a victim of some political factors. I think the adolescent sexual and reproductive health agenda has in general slipped somewhat in the global context, and there needs to be a broader effort to revitalize this. And one of the things that Women Deliver, in fact, is doing is that there is reaching out to youth initiatives, to youth groups, and engaging with them around this issue specifically. So stay tuned on that front. Jessica had a very interesting question about how we define linking. Are we actually talking about working together with other organizations and other movements, or are we talking simply about modeling, using their approaches as a model? I think, honestly, it's a little bit of both. I mentioned during my presentation that there's been some real efforts to reach out to and link up with the HIV and AIDS activist community. And I think that there is genuine interest on both sides. To be honest, there's some wariness on both sides as well. I think one of the big fears that the maternal health community, and Betsy could probably comment on this, that the maternal health community has is that, as I mentioned at the very beginning, one of the Lancet article to help launch the Safe Motherhood Initiative was where is the M in MCH? And part of what was found at that time was that MCH, maternal and child health programs in much of the developing world were in fact 90% or more focused on child health interventions. And I think there is a little bit of a concern within the maternal health community that if we link up with that full MNCH agenda, or link up with HIV, or link up with primary health care movement and agenda, that maternal mortality will once again be subsumed. And I don't think I honestly don't think that's a risk. I think we have an MDG, we have a level of maturity now that I think we can only be strengthened, I think, by linking up with other similar groups that have a linked agenda. And I think that's really an important part of our strategy moving forward.
Oh. Yeah, can I?
Yeah, go ahead.
Yeah. Because I thought those were three very interesting questions, and rather than address them individually, I'd like to extract a theme from them, which is defining the issue. How does the issue get defined? And how does it link up with other issues? And I'm not going to offer any advice because I don't have any wisdom about this, but I just want to point to a broader social process in global health, and I hope I don't use too much jargon. I'll try to be quick. But it seems to me that advocacy groups are engaged in a process of strategic social construction where they take issues and they frame them and they try to get support for their issues. They believe they're actually dealing directly with reality, but they're actually constructing issues. And so it's interesting to see the evolution of issue frames for maternal mortality. For most of its history, it's been the safe motherhood issue frame, and it's been focused on maternal mortality. There was a decision, in some ways pushed by Gates and the British, I believe, to get maternal newborn child together. And it's been the partnership's mandate to create this new issue frame, MNC. And some will embrace it wholeheartedly and think it's a great wisdom, and some will yell at it and think it's a terrible idea. But they're all engaged in strategic social construction of the issue. Now, you could imagine an issue frame that combines maternal and AIDS. The AIDS folk have been the best. They've pushed the issue frame of AIDS exceptionality and AIDS as a threat to humanity. They've been masters of the issue frame. So I'm just pointing out a social process going on in global health, and I'm not offering advice.
Okay, I think we've got time for a couple more questions. Let's go way up here to Al.
Thanks. Al Bartlett. I work on maternal and child health at USAID, and this is sort of a USAID in question, I guess. Actually, a question for Jeremy and a couple of thoughts to share with Anne and maybe get her thoughts back. And they're both based on the notion that something that's been said a number of times. Kul Gautam, whom Anne knows well, used to say it on a regular basis, which is that funders don't invest in problems, they invest in solutions. And So the question for Jeremy is, where would you put in your framework, what role would you put for demonstrated success, or perhaps very early on a clearly defined pathway to identifiable success as one of the factors that motivate investment by donors and other funders, including governments themselves? The corollary to that, things I was thinking about during Anne's presentation, the slide that you entitled "Increasingly an African Problem," I believe. When I saw that, I have never seen those data presented that way before, and it really struck me that it's two slides. And one slide says documented success in reducing maternal mortality, and the second slide says, but no progress in Africa. But that notion that we do know how to succeed, I think certainly in child health we've shifted our frame quite a bit towards talking much more about success and much less about need. And that may be relevant to the discussions that I understand secondhand came out of Stockholm, where the maternal mortality community was commended on the progress that's been made since your 2006 statement in getting the advocacy process really moving forward, and then saying, well, now it's time to demonstrate on the ground how this will work. And so that question of how does demonstrating success fit into this advocacy package is the fundamental question.
Very interesting question. Thank you. I'll give you. I'm sorry, I'm being an academic here, Ann, but I want to give a hypothesis. So, the hypothesis would be that documented success is attractive for attracting donor funds, but don't do it too much because you always want to appear neglected. Right. If you're doing it by yourself, there's no need for extra support. You always have to push yourself as neglected. And that gets back to strategic social construction. Documented success itself has a bearing, connection to reality, but, what do you mean by documented success? That gets strategically socially constructed as well. People make claims about success, and some push success claims, and others push different success claims, so you get these games going on. So I'm taking a step away from concrete material reality to think about the role of ideas.
Okay, so from a non-academic perspective, but I actually would go back to Jeremy's framework, because he does have as one of the key elements of his framework the existence of effective interventions, and that's how I would frame what you've just talked about, Al. I think it is critical for us to say we know what the solutions are and we have evidence that they work. It's still important, as Jeremy said, to say, but hasn't been enough of an investment in them, and therefore we haven't achieved yet the success that we know we can. But if we do these things, if we get this much money, and if we do these things, then in 5 to 10 years we can achieve the MDG5 target. That's, I think, what has to be at the core of our message. The challenge now is to figure out where the money is going to come from, and those are the discussions that's why the high-level task force is probably, if I had to say, the most important thing that is going on in this global discourse right now.
Okay, I think that academic and non-academic, very Wilsonian way to end this event is great. Please join me in thanking the presenter.